Thank you very much, audience, for sitting behind for the last man standing. In my presentation, I will be just discussing only a single case because either you or your patient or both of you need to be really unlucky to have a worse presentation than this. So this is a case of a 13-year-old female who came with complaints of decreased right eye visual acuity since almost a month. She had history of intestinal obstruction a year ago and was diagnosed as having abdominal tuberculosis since 1 month and was on ATT treatment. On visual acuity, in the right eye was hand movement and the left eye was 20/50. So this is the fundus photograph of the left eye of the patient, where there was presence of a large neovascularization of the disc with a peripheral vasculitis features and NVEs elsewhere. And along with that, there were fibrovascular proliferation in the inferior quadrant. On doing the B scan for the right eye, there was presence of significant vitreous hemorrhage with a retinal detachment and a suspected subretinal hemorrhage also. So before moving on to the management of the left eye, we did a fluorescein angiography for the right eye. So this is the early FFA easily demarcating the NVD over here, and significant amount of vasculitis and ischemia, as Dr. Basu had pointed out in these patients. So this is the mid phase and in the late phases where we can see significant amount of leakage in this eye. So we came to a diagnosis of bilateral tuberculous vasculitis with right eye having additional vitreous hemorrhage with an RD with a subretinal hemorrhage. And for the left eye, we started pan-retinal photocoagulation, and the right eye was advised the vitreoretinal surgery. So now we'll just go through the surgical video of the patient. So we start with doing a core vitrectomy. So in all these patients, they usually have a very dense vitreous hemorrhage in vasculitis. So it's very important to start with a very low cut rate, and doing an anterior vitrectomy is also very important in these patients because most of them are phakic. So removing the anterior vitreous is very important in order to get a better view of the posterior part. And the PVD induction is usually very challenging also in these patients. So as you can see, I'm slowly dissecting. And unfortunately, there was a combined RD also when I went inside. So there was already a break in the superior nasal quadrant from where there was a significant bullous detachment was there. So a careful PVD induction was required in this patient, and we usually do it in the shave mode, especially in the peripheral portion, because since these patients are phakic, doing the peripheral vitrectomy with scleral indentation is very important to avoid lens touch, and adequate amount of hand exchange is also important. So this was the break that was there in the combined detachment through which I am draining the subretinal fluid. And as I drained the subretinal fluid, the RD did not settle. So I did a retinotomy in the superior nasal quadrant and tried to remove more fluid. And as we see, as I'm removing more fluid, we can see the subretinal hemorrhage more clearly at the entire posterior pole. So then I started doing a little bit more dissection in the inferior quadrant, and this is all blood-stained vitreous that is there in this location. So with careful scleral indentation, I did as much PVD induction as possible over here, and there was a small break that actually developed in this quadrant. So through that only I started draining the subretinal fluid because it was a lower quadrant that was very bullous for this patient. And then after that I did a fluid eye exchange, and I thought, let us try to see if the retina is flattening or not. Now at least I was lucky at this stage that the retina gradually started flattening. We can see these beautiful choroidal tessellations that can be seen in this area. So at least the lower quadrant settled, and then through the break of the combined RD and through the retinotomy, I drained the remaining amount of fluid. So thankfully she was doing fine. Now the next challenge came managing of the submacular hemorrhage. So what do we do in these patients? So I did a couple of retinotomies. Now the decision to do a retinotomy at the macula is usually very challenging, but removal of this blood is very important, because if this kind of blood stays in this eye for even about 10 to 14 days, then the patient is going to develop this dehemoglobinized blood, and she may never get back the visual acuity back. So a careful removal of the blood was done through that area, and a laser is very important in all these peripheral locations as well as to the retinotomies in this area. So I did the endolaser to the retinotomy also, that was done in the inferior nasal quadrant. And at least 2 or 3 rows of these endo laser is very important. Otherwise, this can be the cause of a secondary detachment that can happen in the post-operative period. And this is the temporal vasculitis area where we can see all these sclerosed vessels. So very good amount of laser is important. Otherwise, the patient may develop recurrent bleeding at a subsequent stage. Then usually for the last part of the drainage of the subretinal fluid, I actually increase the FAX pressure to 60 millimeters. So that usually helps us to create a bone dry type of macula. And here if we see a very small residual amount of blood clot was remaining over here, but the fovea thankfully was cleared at this stage. So at least I was happy with this kind of an outcome at this stage, and I did the endo laser to the retinotomy that was in superior nasal to the macular area. So here I try to do only a couple of rows of laser treatment so as to avoid going close very to the macula, and at the end a silicone oil injection was done for this patient. So this is the day 1 photograph of the patient where her visual acuity improved at least from hand movement to CF 1 meters. We usually see this cataractus development in the early post-op periods, whenever we put either a gas or a silicone oil. Now thankfully after 4 weeks her visual acuity improved to 20 by 100, and this is the fundus photograph of the right eye of the patient where we see the scarred retinotomies, and in the left eye also the laser marks were done. And this is just the OCT of the right eye, which shows a very nicely attached macula. And unfortunately, a month later, she came with recurrent bleeding in the left eye, for which I advised surgery also. But the patient then developed ascites and multiple taps were done, and she got admitted in the ICU for about a month. So she has not yet received fitness for the other eye surgery. So I'm awaiting her follow-up anytime in the next 2 or 3 weeks. Thank you very much for your patient listening.
Thank you, Dr. Jay, for sharing such a wonderful case. So, I wanted to ask Dr. Modi, when do you take a call of surgery when vasculitis, there was definitely retinal detachment under it, so it had to be operated. But if it is a plain vasculitis with vitreous hemorrhage, when do you take a call for surgery?
So, if there is active vasculitis and if there is retinitis, we would want the inflammation to get control if we are sure that there is no retinal detachment. And once that is done, a lot of times we can see that the visual axis has cleared by that time. So we can just get away with doing laser. So vasculitis is like multiple BRVOs happening. And again, the principles what we use for diabetic vitrectomy are the ones which are used over here. And slight, beautifully done case, surgery, Jay. I would think, what do you think about the role of subretinal TPA in this instead of creating a drainage retinotomy very close to the fovea, because that is slightly tricky, and the role of PFCL probably
I did the subretinal TPA. I did not think at that stage because the bleeding was still fresh, so it could have got displaced by maybe a gas injection itself. The underlying pathology for the subretinal bleed happening in this case is most probably because it was a combined RD and there was a vitreous hemorrhage that was there. So it was a vitreous hemorrhage that had actually liquefied, and through the break it had gone behind. So a more of mechanical removal was needed. PFCL, there's one option by which we can try to displace it to the periphery and try to remove it to the retinotomy. But yes, that's a good suggestion.
Another question I wanted to ask, a role of anti-VEGF in VH related to vasculitis.
Yeah, so again, if there are multiple NVs and there is leakage shown, anti-VEGF will help us regression of NVs, reduce the risk of intra-op bleed. So yeah, I do sometimes use in some patients pre-operative anti-VEGF.
So it's like a diabetic TRD where you inject a week prior and do surgery.
Yes. In this case, probably I would have thought about injecting anti-VEGF pre-operatively.
Similar question to Dr. Basu, if you want to add.
Anti-VEGF, you also need to be careful because of the risk of TRD. So I personally do not use so much anti-VEGF. But just a point about why the subretinal hemorrhage happened. So whenever you have a combined RD, there's usually a vessel where the break happens. The breaks are at the base of the TRD, of the fibrovascular proliferation. So there are active vessels there, and they bleed and they go either ways. Some blood will go behind the retina, some will come in front.
Thank you, sir. Any thoughts, Dr. Kelgaonkar, if you want to add for the same? Okay. Thank you so much, Dr. Sheth. Questions from audience.
Since the patient was phakic and the periphery you wouldn't have been able to treat, so would an anterior cryo would have helped for the periphery?
I was able to get a good amount of laser for the patient. So usually ARC I do not consider unless the patient has recurrent vitreous hemorrhage. Very similar to what we see in PDR patients where they have an anterior hyaloid proliferation. So usually those are the indications where ARC is usually helpful in these eyes.